Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Dave Stukas. I'm a board-certified allergist and immunologist and serve as the social media medical editor for the Academy. Our podcast series will use different formats to interview thought leaders from the world of allergy and immunology. This podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Finally, use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at www.aaai.org. Today's episode of Conversations from the World of Allergy comes from our Ask the Researcher series. Also, quite frankly, it's from our Hot Topics series as well, as you'll find out soon enough, where we interview leading researchers regarding their work and careers. We are very fortunate to have today's guest join us as our first international guest. Dr. Brian Lipworth is a clinical professor of molecular and clinical medicine at the Scottish Centre for Respiratory Research at Ninewells Hospital and Medical School at the University of Dundee in Scotland. Dr. Lipworth has established an international reputation investigating various aspects of clinical airway research and has over 500 peer-reviewed publications. Recently, Dr. Lipworth has published in both the Journal of Allergy and Clinical Immunology and Journal of Allergy and Clinical Immunology in Practice on the topic of COVID-19, which is what we're going to discuss today. And I think this is going to be a fascinating conversation for all of our listeners, and I'm very much looking forward to learning more. Dr. Lipworth, thank you so much for taking time to join us today, and welcome to the show.
Well, thanks very much, Dave. It's a real privilege and an honour for me to do this, and I hope we can have an informative chat over the next half hour or so. So thank you very much to the Academy for inviting me.
Oh, it's our pleasure. Well, before we get into some of the details regarding COVID-19, we're recording this episode in late July 2020. And, we all know that daily COVID-19 cases have reached an all-time high in the United States. How are things where you are in Scotland and in the United Kingdom currently?
So if we look at the UK wide, which includes Scotland, we're talking about 295,000 cases, that's PCR swab positive, and about 45,000 deaths, which are attributed to COVID on the death certificate. So that's population, just to give you an idea, in the UK, about 68 million. In Scotland, which has got a population of 5.5 million, we're talking about 18,500 cases, and of those PCR positive, and of those about 2,500 deaths. Just to bring you up to date, I just had a little sneaky peek on the website before I came on, and today or yesterday in Scotland there were 22 cases and no deaths, and in the UK there were 580 cases and 12 deaths.
And have you observed any key differences in regards to public health measures employed in Scotland compared with other parts of the United Kingdom or really any other countries?
Not really. We don't really have the main thing really here compared to, say, the Far East, is our track and trace system is very, very rudimentary. There was meant to be an app that they brought in, and they found that it just wasn't fit for purpose. So I think they're getting into bed. The government are getting into bed with Google and Apple to develop a better app for track and trace. So they've managed to ramp up the testing to more than 100,000 a day after a bit of a slow start. But there's no real difference between Scotland and the rest of the UK. The only main difference is the Scottish government has held us in lockdown for quite a bit longer than down in the rest of the UK, in England, Wales, and Northern Ireland. So, for example, I'm still not seeing my patients face to face. We're only seeing emergencies face to face in clinic, so cancer patients, that kind of thing. But for asthma patients and my patients with allergic rhinosinusitis, which are my two main interests, we're still having to do everything virtually. We're still not up and running with doing lung function tests yet because of aerosol generating concerns. So yeah, we're still quite a bit far behind here, to be honest with you.
Interesting. So the pictures that I saw from the last couple of weeks with the pubs opening up, say in London and other areas, that doesn't apply to where you are.
They just opened up here last week, so I'm sure we're going to see some regional spikes. Will we get a second wave? I don't know. I think what we'll do is we'll probably see clusters in certain cities. So we've seen some clusters in places like Bradford and Leicester down in England, in the Midlands and the north of England. And I guess we'll probably see the same in Scotland. We'll see some small regional clusters and spikes. But I don't think, and obviously I hope that we won't see a full-blown second wave in Scotland if people behave themselves.
No, I hope so as well, and I hope that you stay safe, and I hope everything goes well with sort of resuming some aspect of normalcy.
Appreciate that.
Now, prior to this COVID-19 pandemic, your extensive research career is focused on various aspects related to the pathophysiology, pharmacology, and even public health measures related to airway disease. And to me, it seems like you were perfectly primed and ready to offer new insight once this terrible pandemic came into our lives. Can you offer some insight as to what piqued your interest in learning more about this pandemic?
Well, it's really expediency more than anything else because my airway research, my upper and my lower airway research, was knocked on the head. Um, so we had to furlough. We had to furlough all of my staff, my research staff. My clinical fellows, they went back onto the COVID front line. So really, I thought, well, it's really something that I have to do. Um, I run a regular blog actually on LinkedIn, and I started reading more and more about COVID. And I thought, well, you know what? I think there's probably something that I can offer here, particularly to my allergy and pulmonology colleagues. And that's really how I got into it. And then, the more I read, the more I was interested. Started writing a few editorials, as you mentioned before, and now I'm setting up some research, which we can maybe discuss later.
Mm, absolutely. That's fantastic. So, and before we get into some of the details, would you mind sharing just in general with your career, what aspects of clinical and translational research do you really enjoy the most?
Well, my research is mainly focused on airway allergy. So, although I'm a certified pulmonologist, um, I'm mostly interested in airway allergy. So, upper airway allergy in terms of allergic rhinosinusitis, nasal polyposis. I run a rhinology service in concert with my otorhinology colleagues, my surgical colleagues here. We have a one-stop shop clinic, which I've been running for about 20 years now. And then lower airway, obviously asthma and some COPD as well. But what I enjoy the most, to answer your question, I enjoy designing the clinical trials, finding questions which I want to answer for my own clinical practice. That's always what's driven me. So if there's something which has been bugging me, which I think is an unmet need in clinical practice, and it's relevant to patient care, I'm not a bench researcher. I'm more of a patient-focused researcher, more translational research. Then that's what I do. So I enjoy reading the literature, finding where there's an unmet need, designing the clinical trial, and then I enjoy, there's nothing more exciting than sitting down with your research fellow and looking at the data as it starts coming through, and then weaving the picture to try and write the paper to get it published in a decent journal like JCI.
So it sounds like that's fantastic, and I know that we all appreciate the work that you do. But it's a little bit different than people, doing their quote unquote research by going onto Facebook and finding their echo chambers. Would you say?
A little bit, yeah. I mean, the other thing which I enjoy is, yeah, I actually like seeing the clinical fellows move on. I'm really proud that 4 of my old clinical fellows have now got their own chairs. So it's really nice to see them doing very well, moving forward. So I really do enjoy mentoring the clinical fellows, and I think I've mentored now about 25 clinical fellows over the years. Some better than others, having said that, but it's I still do like training the fellows and bouncing off them. There's nothing like having a bit of youth in the department. And my mantra is surround yourself by people who are much cleverer than you.
Wise words, and your enthusiasm comes through very well. So that's great. Thank you for sharing that. Okay, well, let's get into the meat of the conversation. So let's just sort of establish a baseline here for our listeners, so everybody's on the same page. Let's go to basics. Can you describe what type of virus SARS-CoV-2 is, how it spreads, and what it does inside the human body?
Yeah, so SARS-CoV-2 is one of the family of coronaviruses. And these are basically single-strand RNA in an envelope with glycoprotein spikes attached to them. And the family includes the common cold coronavirus, which is seasonal. And then the other coronaviruses are MERS-CoV, Middle East Respiratory Syndrome, SARS-CoV, which is the SARS outbreak, and then more recently the COVID, which is SARS-CoV-2. Now, these are all zoonotic viruses. In other words, they're transmitted from animal reservoirs. MERS came from camels in the Middle East, apparently. SARS came from bats. And the current thinking is that COVID, SARS-CoV-2, also comes from bats, and perhaps other animals are intermediary in transmission in terms of the zoonotic reservoir. So I think there's some thinking, it's not proven yet, that pangolins are also involved as an intermediary species in the transmission of COVID. How does it spread? Well, it spreads by droplets and obviously contact either from the human body with your mouth, nose, or eyes. The first port of call to get inside the body is actually the nose. When you think about it, 30 to 40% of COVID patients who are affected by the virus get anosmia or hyposmia. Actually, there's some really, really nice research. There was some reverse genetics data published in Cell, which was really neat, which showed that the expression of the receptor onto which SARS-CoV-2 hitches a ride, which we'll come to later, which is angiotensin 2, the expression of that is actually much higher in the nose with a descending gradient as you go from the nose down the respiratory tree. And if you actually look at the infectivity with SARS-CoV-2, it's much higher initially in the nose than it is in the lower airway. So consequently, if you want to protect yourself, wear a mask and make sure that your mask fits over your nose, because that's the first port of call for the virus. So once it gets into the nose, of course, you get rapid nasociliary clearance into the pharynx, and from there it aspirates into the lung, and then you can either get the local lung manifestations, the COVID pneumonia, pneumonitis, or the systemic response, which we'll maybe discuss later.
That's fascinating. Now, in regards to risk factors, what's really emerged as some common patterns in regards to those who experience severe infection from this virus? And are these the same across the world, or does it change based upon location?
So the main risk factors are men more than women. There's ethnic factors as well. So black people, Asian people seem to be more susceptible. If you're obese, that's a risk factor. It's probably not obesity per se. That's probably metabolic syndrome. So obesity, hypertension, diabetes, all linked together. So as I've said, hypertension, diabetes, big risk factors. And then you've got chronic heart disease, chronic lung disease, asthma, COPD, chronic kidney disease, and finally neoplasia, or patients who are immunosuppressed for one reason or another. So those are the main risk factors, and the more risk factors and obviously if you're over 70, is a big risk factor because you've got these age-related comorbidities. Although it has been shown in that regard that expression of Ace2, the receptor which SARS COV2 hitches a ride into the respiratory epithelium, the expression of ACE2 is actually age-related. And that's been shown in the nose, actually. So the older you are, the more ACE2 expression you've got. Males, why are they more susceptible? Well, that's thought that testosterone, a steroid hormone, upregulates the ACE2 receptor. Is this the same across the world? Pretty much so, with a few regional tweaks here and there. Does location matter? No. SARS-CoV-2 has no respect of where you live or what you do.
Oh, that's all right. Thank you for that background. And I want to get back to the ACE2 receptor in a second, but before we do, can you describe what we've learned as far as the end organ effects that occur in people who have severe infection and/or death? You mentioned before about how it seeds through the nose, and a lot of people, will have upper and lower respiratory symptoms. But what else have we learned?
Well, as I said, the first is it goes to the nose, then to the lung. And then in susceptible individuals, which I've just outlined, those with comorbidities or elderly people, then it causes the COVID pneumonia. If you get severe pneumonia, then you'll become hypoxic and you'll have a need for oxygen, and then you'll need to be admitted to a hospital. Once the virus then goes systemically, because the lungs are a brilliant way of getting anything into the systemic circulation. It's said the lungs are, if you unravel the lungs, they're sort of the size of a tennis court. So once it gets systemically, then you get an adaptive immune response, and that through various pro-inflammatory cytokines involves multiple organs. So extrapulmonary manifestations in the brain, you can get confusion, encephalitis, seizures, strokes. In the heart, that can give you myocarditis, cardiac arrhythmias, hepatitis in the liver, a nephritis with acute kidney injury and renal failure. Gastroenteritis is quite common. You can get lesions on the skin which look like sort of lupus pernio. And of course, the really, really big killer in COVID, aside from hypoxic pneumonia, is the endarteritis and thrombophilia, which this virus seems to induce, which results in disseminated venous thromboembolism. So as well as getting the COVID pneumonia, you get the double whammy that you often get venous thromboemboli and pulmonary emboli, which worsens the hypoxia due to worsening of the ventilation perfusion mismatch. And that's why all patients admitted to hospital, the first thing that happens is you get a jab with low molecular weight heparin to try and prevent that.
Interesting. I realize as we go along in this conversation, I don't necessarily like what I'm hearing, but nonetheless, we can't ignore it. And this is very important information for all of us to understand.
I mean, the way that I actually think about COVID-19 is that I actually think of COVID-19 as manifesting as a viral-induced cytokine-mediated autoimmune disease, which is characterized by hyperinflammation and coagulopathy. That's how I would kind of summarize what we're talking about here.
That's really fascinating. And actually, I was just about to ask you about that. So can you describe to us what do we know about the types of immunologic mechanisms that have been identified in these severe COVID patients? And then we'll talk about cytokine storm after that. Or if you want to roll it into one, that's fine as well.
Well, you're getting an adaptive immune response here with macrophages, T cells, and B cells. And then as a consequence of that, in certain susceptible individuals, which seems to be these, older patients with comorbidities, that's when you get release of these pro-inflammatory cytokines. So the main players here are interleukin-1, in particular interleukin-1 beta, interleukin-6, and TNF-alpha. There's various other cytokines and chemokines, but those are the ones that when you actually measure it in patients with severe COVID, so these are hypoxic patients or patients who've been intubated and being mechanically ventilated, the really sick ones, they're the ones that have the highest levels of cytokines. And that's what we mean by the cytokine cascade or or the cytokine storm. These are the patients who've got this adaptive immune hyperinflammatory response. They're susceptible individuals, and that's what's causing the end organ damage, and it's also causing the hyaline membrane deposition in the alveoli, which is giving you the acute respiratory distress syndrome, ARDS. And once you've got that, you're unlikely to come out of the ITU, to be honest with you.
Mm. Do we have any idea why some people have that switch flipped and others do not? And more importantly, can we stop that switch from being flipped in the first place?
Unfortunately, at the moment, we don't. We know which patients are. We know which patients are more susceptible to that. That's been shown in some of the big databases. The one that springs to mind is the UK Open Safely database, which is in 17 million UK patients. And that database again showed that the patients who end up being admitted to hospital and who end up being on ITU and die are those very patients, with the common comorbidities, which I've just outlined, and the ethnic susceptibility as well. But in terms of, can we get, say, an immunological endotype? That's what you're asking, to say who's going to end up in ITU and who isn't. At the moment, we don't know that. What I can tell you is, because it's some data that I published with a group in Munich that we published in JACI. The first author was actually Tobias Herold from Munich. And what we showed in that paper in JACI that we published was that, in fact, if you are admitted to hospital, the strongest single predictor of whether you're going to end up on a mechanical ventilator and need to be intubated is actually your levels of interleukin-6. It has a very high predictive value in terms of whether you're going to end up being on a ventilator. And from memory, I should know because I was an author on the paper, I think if your IL-6 level is greater than, I think it was 65 picograms per mil, that's associated with a 22-fold increased risk of needing mechanical ventilation. Now, you might say, well, do we usually measure interleukin-6 in patients admitted? No, we don't. And what we use is a surrogate because, as you may know, interleukin-6 stimulates hepatic synthesis of C-reactive protein. So C-reactive protein and IL-6 track very closely to each other. So the second strongest predictor, unsurprisingly, of need for ventilation was CRP levels. So if your CRP level, which most people are more familiar with than IL-6, if your CRP level on admission to hospital is more than 35 milligrams per litre, or during the course of admission, if it goes up above 95 milligrams per litre, that has a very high predictive value that you're likely to be ventilated. So the message there is if you're dealing with sick patients, if your CRP is raised on admission, or if the trend is for the CRP to be creeping up, that should be a very clear indicator to the clinician to start thinking about escalating treatment.
In regards to, really we're talking about biomarkers that can be useful to help, predict severity. Have other biomarkers been investigated, and, do you recommend anything else at this time?
Well, there are other biomarkers. There's things like lactate dehydrogenase, LDH. There's D-dimers. There's ferritin, lymphopenia. But when we compared all of these in the Tobias Herold paper in JACI, as I said, IL-6 had the highest value for the area under the curve from the receiver operating curve in terms of combined sensitivity and specificity for predicting worse outcomes. And in fact, an Italian group took that a step further. And what they did was they looked at sick patients admitted with severe COVID hypoxic pneumonia, and found that when they combined a composite score with IL-6 CRP and the ratio of oxygen saturation to the FiO2, in other words, the inspired concentration of oxygen, they found that those three in a composite score gave you the highest predictor. And I'm sure that if you actually ended up putting in D-dimers as well, you'd probably find that the AUC would start creeping up and up and up. So, I would imagine by now, and I hope by now, that, you'd have an app on your phone with a very simple algorithm where you'd put in the the SaO2, maybe the SaO2 to FiO2 ratio, what's called the SF ratio. You'd put in either your CRP or your IL-6, whichever you've got. You might also, I suspect, put in your D-dimers, maybe a lymphocyte count, and it would say, on admission, your patient has got a 80 or 90% likelihood of needing ventilation. And in that patient, you think, right, well, I'm not going to mess around. I'm going to crack on and escalate their anti-COVID therapy.
Oh, it's so fascinating. And in your experience and understanding with the IL-6 level, is that something most, hospital laboratories can easily run, or does it need to be more of a send-out lab that takes some time to turn around?
No, that's I think Roche make a commercial assay for it. But having said that, here in Tayside, we don't run the IL-6 assay. We run CRP, which tracks very closely to IL-6 actually. So you could argue that that you probably don't need IL-6. Every lab measures CRP. So if you're using CRP, as I said, a cutoff of more than 35 on admission, or during the course of illness, if it goes up to more than 95, that's bad news.
Okay. Oh, that's so helpful. Now let's go back to this ACE2 receptor that you mentioned before. We have listeners from various backgrounds from across the world. Can you just give us some basic information in regards to what that receptor does, and just restate why it's important with SARS-CoV-2?
Okay, so let's go back to the beginning, Dave. So angiotensin 2 is actually a counter-regulatory enzyme that modifies the effect of the renin angiotensin system. So what I mean by that is it modulates the effect of angiotensin 2, because it breaks down angiotensin 2 into its substrates, which are angiotensin 1 to 7 and angiotensin 1 to 9. And they actually have the opposite effects of angiotensin 2. So, for example, while angiotensin 2 is a very potent pulmonary and systemic vasoconstrictor, angiotensin 1 to 7 does the opposite. It's a vasodilator. So if you like, it's the natural physiological break to the renin angiotensin system. So the way that coronaviruses hitch a ride into the respiratory lining epithelium is that they hitch onto the angiotensin 2 receptor through the spike protein. Now, there's another side to this story. It's not just ACE2. There's another receptor, which is called TMPRSS2. And that stands for transmembrane protease serine 2 receptor, which is a protease. And what that TMPRSS2, which is less of a mouthful, what TMPRSS2 does is that it actually primes the spike protein so that it can latch on to the ACE2 receptor. So you've really got to think of ACE2 and TMPRSS2 in concert. You can't really think of one without the other, to my thinking, because it gets in the cell by priming the spike protein with the TMPRSS2 and then latches on. And then once it latches on to the ACE2, that gets endocytosed into the respiratory epithelium, and then you're into the cell, and then you start to get the adverse effects of the virus. So the theory, and this is still just a theory because I don't think it's been categorically proven. The theory is that if your ACE2 levels are lower, that might conceivably lead to a lower propensity for COVID-19, because you've got less receptors for the COVID virus to hitch a ride onto. And the same would apply to TMPRSS2, that the lower the expression of ACE2 receptors and TMPR SS2 receptors, that would you would expect to lead to an attenuation in terms of the viral load. It won't prevent you getting the virus, but your degree of viral load would be less. Now, that's not actually been proven yet, but it does seem to be a cogent hypothesis.
Mhm. Yeah, and you mentioned before about how age can impact the expression of the ACE2 receptor, but what do we know about medical conditions or even medications that result in higher or lower levels of that receptor? And does that impact the likelihood of having more severe illness from COVID-19?
Okay, so age, we know, definitely gives you increased expression of ACE2. Smoking, that's a big one.
Mm.
That's been shown in small airways and in the nose that smoking increases ACE2 receptor expression. Diabetes increases ACE2 receptor expression as well. There are drugs which can increase ACE2 receptor expression, particularly the angiotensin receptor blockers. So they can increase it. However, like most things, Dave, it's not that simple. Because if you reduce ACE2 receptor expression, you then remove that counter-regulatory effect on the renin-angiotensin pathway, if you remember. So what will happen is if you take ACE2 out by down-regulating it, you'll have unopposed levels of angiotensin 2. And angiotensin 2 is actually not good for you. As well as causing vasoconstriction, vascular permeability, it also has adverse effects on myocardial remodeling and fibrosis, and also causes acute lung injury. But anyway, there has been a lot of hoo-ha. I don't know whether that's a Scottish term or not, whether you use that in America. But there has been a lot of hoo-ha about angiotensin converting enzyme inhibitors, ACE inhibitors, and angiotensin receptor blockers, ARBs. And when the whole hoo-ha came out in March, people said, stop your ACE inhibitors and your ARBs because it upregulates ACE2 and it'll mean you'll have a higher viral load. The studies that have been done, and these are mostly health informatics studies. So now there's been a meta-analysis that was published recently and a big observational study from Denmark that was published in JAMA. And the verdict now is very clear, is that ACE inhibitors and ARBs definitely do not increase your susceptibility to getting COVID-19, and they don't predispose to worse outcomes. So the message is clear. If you're on an ACE or you're on an ARB for hypertension, diabetes, or heart failure, keep calm and carry on.
Oh, wow. There's so much to unpack there. But what about any conditions or medications that may lower the levels and actually decrease susceptibility? Things such as allergic rhinitis or asthma or inhaled corticosteroids.
Great question, Dave. So, where are we thus far with the data? There's a lot of data to unpack here. The first thing that we know is that asthma per se doesn't have any impact on ACE2 expression. That's the first thing. And these are studies that have been done looking at retrospective cohorts from patients who've either had a bronchial brushing from endoscopy or who've had a nasal brushing. So, these are things like severe asthma cohorts where this has been done. The second thing that we do know is that your degree of IgE, immunoglobulin E sensitization, has an inverse correlation with your ACE2 expression. There was a paper by Jackson and Jackie this year which showed that very elegantly, showing that the higher the level of your IgE sensitization, these were asthma patients, that you get a proportional reduction in ACE2 expression. The other thing that was shown is that if you actually have an allergen challenge, so if you go into an allergen changer, or if you actually have a segmental allergen bronchial challenge, that also leads to reduced ACE expression. The other thing that's known is that type 2 inflammation, which obviously atopy and eosinophilia are integral parts of, also affect the way these two cell entry receptors are regulated. So what I mean by that is that if you have type 2 high inflammation, so in other words, if you're atopic or you've got eosinophilia, that downregulates ACE2, but interestingly, it paradoxically upregulates TMPRSS2. So you've got a kind of a push-pull system here, with ACE2 being downregulated and TMPRSS2 being upregulated in association with type 2 inflammation. And the mechanism for that has now been elucidated. And that was shown very elegantly, again, in another paper in JACI, where they found ex vivo that if you stimulate with interleukin-13, which is one of the key type 2 inflammatory cytokines, that has exactly the same effect. In other words, IL-13 stimulation downregulates ACE2 expression, but upregulates TMPR-SS2 expression. So the net effect actually might be null because you're getting this push-pull effect. To answer your other question, you asked, are there any treatments which will alter expression? Mm-hmm. And the answer is yes. And there was a very elegant paper in the Blue Journal by Peters, which is actually an index paper, which showed that patients taking inhaled corticosteroids have downregulated expression of both ACE2 and also of TMPR-SS2. And they showed a nice dose-response effect comparing low to medium dose and high dose. But interestingly, in the same study as a negative control, they found that inhaled steroid had a null effect on ICAM1 expression. And ICAM1 is responsible for rhinovirus infection, whereas ACE2 and TMPR-SS2 are involved for SARS-CoV-2 entry. So I think that was a really elegant study showing that corticosteroids can downregulate COVID-related genes. These were shown in induced sputum of asthma patients, so over about 300 patients from memory.
That it's so fascinating. So to summarize, if I may, from what I'm hearing, for our patients, the millions of patients across the world that suffer from common allergic conditions, allergic rhinitis and asthma, it doesn't sound like we have great news. It doesn't sound like we have terrible news. It sounds like, as you mentioned, if I may, keep calm and carry on, keep taking your medications, keep your conditions under control. Does that sound about right?
Yeah, in fact, that was the exact title of a leader I wrote in Annals of Allergy. It was Inhaled Steroids for COVID and Asthma, keep calm and carry on. Now, right, so there is actually health informatics data, which I think is worth briefly discussing. So I don't want to plug the UK NHS too much, but I am very proud of it. So if we go back to the Open Safely cohort, what they did is they looked at over 800,000 asthma patients. So, this has got a lot of power, which is why I want to talk about it briefly. And these patients, 3/4 of them were taking low to medium dose ICS, inhaled steroid. About 15% were taking a high dose, and the rest, about 10%, were just taking albuterol alone. And what they did is that they looked at the adjusted hazard ratio for ICS use compared to albuterol alone, so with inhaled steroid, without inhaled steroid, in these asthma patients, in terms of the propensity for hospital-related COVID deaths. And what they found was this, is that if you're on a low to medium dose of inhaled steroid, the hazard ratio showed that you have a 10% increased likelihood of dying from COVID-19, but the confidence interval included unity, so it wasn't significant. If you are taking a high dose inhaled steroid, then the hazard ratio jumped up, and it was 1.52. In other words, a 52% increased likelihood of having COVID-related death. And in that case, the confidence interval did exclude unity, so it was significant. So does that mean that taking a higher dose of inhaled steroid predisposes you to dying from COVID. No, it doesn't. It's simply a marker of confounding by severity. In other words, if you've got more severe asthma, because you're just using inhaled steroid dose as a proxy for asthma severity, you're more likely to die from COVID disease. And they actually showed in another paper, the same open safely cohort, that the risk of dying from COVID in patients with or without oral steroid therapy, again as another proxy for asthma severity, was approximately doubled. And I think that's the most robust data, just because of the power of numbers, to tell you what the potential effect is. But my message to my patients, and they ask me this every single virtual consultation I've been doing over the past few months, since lockdown, my patients always say, doctor, I've been reading about, steroids and, they might predispose you to worse outcomes, they immunosuppress you, blah, blah, blah. What should I do? And I say the best thing that you can do to protect yourself from any virus, whether that be, COVID or the common coronavirus or rhinovirus or RSV or adenovirus, any virus, is to keep your asthma as well controlled as possible. And the best way you can do that is to adhere religiously to your inhaled steroid and your other controller therapy. And that would be my take-home message. That's my mantra to the patients.
And to build upon that, I'm sure you get this question a ton as well, and I know this is a common concern. Asthma is this heterogeneous condition, as you know, and it affects millions of people, but it really encompasses very different endotypes, phenotypes, levels of severity, levels of control. We're seeing conflicting messaging from the World Health Organization, the Centers for Disease Control, local governments in regards to asthma being a risk factor for susceptibility to getting COVID-19 or having severe illness from it. What do we know actually from the evidence? I'm sure people are looking at this because, from the person with asthma, their standpoint, they've been told, their whole lives that respiratory illnesses increase risk for exacerbation. Are we seeing the same effect from COVID-19?
We are and we're not. Okay. It is an increased risk. And if you look at the open safely cohort, just because it's the largest cohort, about 14% of patients admitted to hospital with COVID had asthma. So it is, in that regard, it's a risk factor. Any respiratory disease is. But COPD more than asthma in that regard. That's because you've got impaired host defense and an altered microbiome in COPD, and you're a smoker, so you've got a triple whammy in COPD. There's actually a really, really nice table that was just published the other day by Guy Bruxelles in the Blue Journal, and which I actually blogged yesterday on my LinkedIn blog, which really crystallized the question you're asking very nicely. And what he showed, and this is evidence-based, was that the increased risk of COVID-19 if you've got asthma, in other words, looking at the heterogeneity of asthma and the potential risk of severe COVID, which I think is what you're asking me, is that there's an increased risk in older people, in type 2 low asthma, in asthma patients who've got high levels of IL-6, in asthma patients who smoke, in asthma patients who are obese, diabetes, hypertension, other comorbidities. If you've got severe asthma, so if you're on oral or high-dose inhaled steroid or oral steroid, in other words, genus step 5, then you're more at risk. If your lung function's impaired, presumably because you've got less reserve. If your asthma's badly controlled and you're a frequent exacerbator, that's also a risk. And if you have a need for more in the way of oral steroid bursts, and that's just a marker that your asthma's badly controlled. So it brings me back to what I said before. The best thing that you can do as a clinician for your patients is to make sure that they religiously adhere to their controller therapy. And here's the thing, right? It's not just their inhaled steroid. Long-acting beta agonists and long-acting muscarinic antagonists have been shown in at least 2 studies, albeit in vitro, that I've seen, to suppress the cytokines, and in particular interleukin-6. So I think that it's not just the inhaled steroids, it's the long-acting beta agonists and the muscarinic antagonists taken together, which will give you the lowest risk. So we need more health informatics work. That's something that I'm trying to dig into at the moment with national and regional databases to try and tease that out at the moment. The problem is, essentially, with any of these health informatics studies, is that you have this confounding by severity. You know, the more treatment you're on, the more severe your asthma.
Thank you for that summary. I think that's very helpful information for everybody listening, especially our patients as well. I want to respect your time, but I have just a couple more questions, and I'd be
No
remiss.
problem. No problem.
I'd be remiss if I didn't ask you, the big $1 million question. I really would love your insight on this, given your expertise. While the world awaits a potential vaccine or vaccine candidates, plural, for COVID-19, many different treatment approaches are being investigated. We've all seen the headlines and we're aware of the publications and everything that goes into that. But can you summarize what we've learned from these trials and offer your thoughts on what may be the best approach for treatment?
Okay. Well, we don't have anything at the moment that will prevent COVID-19, as you know. Mind you, there was some very promising data published in The Lancet showing that adenovirus vector vaccines produce immunogenicity in terms of an antibody and a T-cell response, which was published on Monday. So that's reassuring. But, we're probably quite a few months off in terms of getting the phase 3 data from vaccines. So let's park that. So we're really talking about secondary prevention for people who've already got the COVID virus and who are sick and been admitted to hospital. What do we know so far? Well, the only drug thus far that impacts on COVID-induced mortality, so this is severe COVID disease for patients admitted to hospital, are the systemic corticosteroids. So that's dexamethasone. So that was a 6 milligram dose of dexamethasone. If you want to convert that to prednisone equivalent, that's 40 milligrams a day. So it's sort of medium dose prednisone therapy, if you like. And that was the UK recovery trial in 2014 patients treated with DEXA and 4,321 who were controls who just had usual care. And the bottom line for that was, in terms of number needed to treat, which is what I understand and what I would tell my patients, is that if you're on a mechanical ventilator and you're treated with dexamethasone, you have to treat 8 patients to prevent a death in 1. That's the bottom line. That's the number needed to treat. If you are on oxygen on admission at baseline, then you had to treat 35 patients with dexamethasone to prevent 1 death. So the more severe the disease, it seems the better the bang for buck is with dexamethasone. But thus far, in terms of peer-reviewed published data, that's the only drug which will have any impact on death. In terms of shortening the duration of illness, as I'm sure most of the listeners know, the Gilead drug, remdesivir, the antiviral drug, shortens the duration of the disease by about 4 days. I believe it's not peer-reviewed yet, but I believe there is some data out there. I haven't seen it peer-reviewed yet. That shows that it might also impact on mortality as well. But I think what I've learned, and I've been blogging this on LinkedIn now for several months, I think the thing that I've learned is that in terms of getting the confidence from any of these trials, it's a numbers game. In other words, you really need trials in thousands of patients to get a confident result. So that's why I'm confident in the result from the recovery trial, because it was in, over 4,000 patients. So what worries me is the trials where you're looking at, 300, 400, 500 patients where you see a bit of a signal. That kind of worries me. So I think we really do need to wait and see what the big national and multinational trials like, the WHO solidarity trial. So what do we know now? We know that dexamethasone impacts mortality. We know that hydroxychloroquine no matter what your president thinks, has no impact on mortality. We knew that from recovery, okay? We also know that the combination of ritonavir and lopinavir, Kaletra, has no impact on mortality. And what we're waiting to find out from recovery and from the WHO trial, Solidarity trial, is we're waiting to hear from azithromycin. I'll fall off my chair if azithromycin has any impact on mortality. I don't think it will do. I'm going, I'm going out with this now. I don't think it will. So where we are at the moment, we've got remdesivir and we've got dexamethasone. What we don't have, and this is a big regret, and I was banging on the door of the National Institutes of Health Research early on in March, and I just got ignored, is that what I wanted to see in these large trials was to look at combination therapy. Because the way I look at this disease is you've got an upstream effect, which is where you can actually interrupt the virus with an antiviral, or you can interrupt the way the virus enters the cell. And then you've got a downstream effect in susceptible individuals who get the hyperinflammatory coagulopathy response. So I think in the sick patients, it's intellectually naive to think that one monotherapy is going to be the answer. You need two. And right at the start, I said to NIHR, why are you not including in recovery a combination limb looking at an upstream modality like an antiviral and downstream modality like a corticosteroid or a selective cytokine antagonist like anti-IL-6? And I think that's been an opportunity missed. Because that's the way it's going to go. In the same way, we've already learned that from HIV disease. One drug is not the answer. And it's going to be the same with COVID-19. It's going to be dual or triple or quadruple therapy. So it's a sort of gain of incremental gains, of marginal gains, that you're going to see a small effect with one, bigger effect with two, and three, and maybe four drugs. And that's my big regret, is that the big national and multinational trials haven't looked at this in a systematic manner. It's been a bit of a scattergun approach, to be honest with you.
Oh, your insight is just spectacular, and thank you for sharing the great summary of where we stand in regards to therapeutic trials and whatnot. But to build upon what you just mentioned, in your opinion, what are some other aspects of COVID-19 that aren't receiving enough attention and warrant additional research?
I think it's the effects on cognitive function, on systemic constitutional upset. Patients afterwards, a lot of them still feel they have cognitive defects. They can't concentrate. They're confused. They're anxious. And I'm not just talking about the patients who've had to spend, a substantive period in ITU, which is stressful enough. I'm talking about the sort of post-viral fatigue syndrome. So, this is going to be a huge burden on the health service in terms of dealing with the fallout of COVID. And of course, we've got the effects on the lungs. You're going to have an interstitial lung disease or idiopathic pulmonary fibrosis, where patients are going to be left with a diffusional defect, a restrictive defect of lung function after COVID. So there are studies. There's a big NIHR study up and running in the UK to look at this in terms of following patients who've got COVID. But I think that's going to be the elephant in the room, is for the people who've been lucky enough to recover and trying to deal with the sort of multifaceted problems which they have.
No, right. I mean, this is still so new, and we have yet to even dive into long-term ramifications from those who have various degrees of severity from illness. So I agree that's going to require a lot of attention moving forward. Well, unfortunately, as you mentioned, it doesn't appear that this pandemic is going away anytime soon. In regards to your own personal plans, do you plan to continue to focus your research in this area? And if so, what comes next?
Well, out of expediency, I think I have to, because my severe asthma patients are still shielding, and the message we're sending out to them is don't come into hospital. We're sending out the message that, we're not doing lung function tests and we're not seeing them face to face. So that's put a bit of a kibosh on my on my upper and lower airway research. So out of expediency, yeah, I think that's really where we've got to go. And we've been told by the government that, we have to concentrate on the sort of emergency health priorities for the moment. So what am I doing? Well, I'm trying to get some research funding from the NIHR in combination with a valued colleague of mine in Liverpool called Graham Devereux. We're both, he's from the Liverpool School of Tropical Medicine. He's actually a pulmonologist I've known for many years. And we've put in an application to the NIHR to look at inhaled and intranasal steroid therapy as primary prophylaxis for patients to see if it modifies the glide path of COVID-19. It's not going to prevent it, but will it prevent admission and adverse outcomes? And I stress intranasal. I've got to be in my bonnet about this because the nose is the first port of call. And I think, to give an inhaled steroid on its own, if we think that's got putative protective effects by downregulating COVID gene expression, Ace2 and TMPRSS2, I think you need to be treating the whole airway, the whole airway if you're going to prevent COVID outcomes. So we're trying to get that study up and running in Africa, in Kenya, where the R rate is climbing on a daily basis. And the reason for that is the Liverpool School of Tropical Medicine's got people on the ground already in Kenya. They're already collaborating in asthma research. So we thought it'd be rude to try and not get some COVID research in one of the townships there where there's very little resource. So that's the first thing. And then the second thing is that, God forbid, there is a second wave here. I hope the second study never comes to fruition. I think I've never said that about any of my research before, but I hope it never happens. I'll be delighted. I'll have a holiday in my heart if it doesn't. It's for the putative second wave in the fall, Q4. Half the deaths in Scotland and pretty much the same in England were actually due to elderly, frail people with comorbidities in care homes, because it just spreads around the care homes like wildfire. So what we're doing a very similar study with inhaled and intranasal corticosteroid, with a particular corticosteroid called cetlesonide, which at least in vitro has been shown to suppress replication of SARS-CoV-2. And that effect has been shown with cetlesonide and bemetazone, actually, but not with betlamethasone, budesonide, or fluticasone. So we've been working that up. We've got a company that's promised to produce us some intranasal and inhaled cyclesonide actives and placebos, and we're going to put in a grant to do that study, God forbid if it ever happens, in care homes in the fall. So that's really where we're putting our efforts, as well as doing this collaborative health informatics work that we're doing in collaboration with some of my colleagues at St Andrews University, Imperial University, Edinburgh, and also with some of my colleagues in Manchester to try and tease out the health informatics, looking at patients with allergic disease, asthma, and COPD to see what can modify COVID outcomes.
Wow, that Brian, your curiosity, your passion, your dedication to truly just trying to help people is so apparent and just truly appreciated by really all of us. And I can't thank you enough for your devotion to this area. And I agree. I hope you never get to launch that last study you discussed.
Yeah.
But if it's necessary, we can't wait to see what you find.
Good.
So, this has been fantastic. And for me personally, it's been extremely informative and quite frankly, very sobering. These are very scary times. But as we wrap up, I do want to try to end on a high note, if I may. So here's my question to you, Dr. Lipworth, as we say goodbye here. Whenever this pandemic has either ended or lessened enough to allow for some semblance of normalcy, where do you hope to travel first and why?
Well, I hope to travel to a place called Machrihanish, which is the most westerly point of Scotland. I actually hope to travel there on Saturday because I've not had a holiday for 6 months. So my wife is going to drag me there. and I've promised not to do too much work in Machrihanish. And I hope to go to Machrihanish, which has it's actually a pilgrimage place for Americans, because it's got one of the finest golf courses in the world, where you actually drive your golf ball off the first tee over the Atlantic Ocean, which is about a 200-yard carry.
Huh.
So it's quite an unusual place. It's got a championship golf course, beautiful sandy beaches, very quiet. Hopefully no COVID. So I'm going there on Saturday. But where would I hope to travel if I got on an aeroplane? I'd probably hope to go back to Oman, just because we've got happy memories of going there before. It's very peaceful. People there are very friendly, and crucially, because we get cold, wet weather in Scotland, it's usually nice and warm even in the winter. So if we can jump on an aeroplane, perhaps in Q1 2021, and travel safely, that's probably where I'm going to head back to get a bit of sunshine, because I won't get it in Machrihanish, that's for sure.
Well, thanks for sharing that. I hope you have a wonderful trip this weekend, and I hope you get to make your next trip as well. And at some point in the hopefully near future, I look forward to seeing you in person and sharing either an elbow bump or an ankle five or an air high five or whatever we'll be doing at that time. But
maybe even a glass of malt whiskey.
Yes, that would be wonderful. I truly look forward to that. Well, Dr. Lipworth, I can't thank you enough for contributing your time and expertise to our show. And before we let you go, do you have any last words for our listeners?
No, just everybody, stay safe, stay healthy. If you're taking inhaled or intranasal steroids, keep calm and carry on.
Excellent. Thank you. We hope you enjoyed listening to today's episode. Please visit www.aaai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through iTunes, Spotify, or Google Play so you can receive new episodes in the future. Thank you again for listening.